but I made an observation yesterday, which I'll make again today, which it seems to me we're in this sort of quite interesting phase where we have what I call the classical view of vitamin D, and then the sort of hopefully not too late 21st century view of vitamin D. So in the classical world of vitamin D, the thing that was considered important was probably serum 125 hydroxy vitamin D, and in the new world it's 25 hydroxy vitamin D. That's the bigger issue. In the old world, the view was that you needed about 400 units a day, and now the new world, it's that maybe you need about 4,000 units a day. In the classical view, a level of 25 nanomolar was considered deficient. Now, if you define deficiency in a sensible way, which is you wouldn't want less than that, it's 80 nanomolars is probably the smallest number, and 100 might be better. Also, in the classical world, there's terms that confuse me as a physicist enormously, which is you can have deficiency and insufficiency and sufficiency. I mean, either you have the right amount or you don't. I think in the new world, we're going to have, grade 4 vitamin D deficiency, which means less than 10 nanomolars, grade 3, which is less than 25 nanomolars, grade 2, which is the recommendation of the IOM as the 50 nanomolars, grade 1, which is your 80 nanomolars, which means you're okay, but you have no reserve, and sufficiency will be considered something sufficiently above 80 nanomolars to give you room. You don't want to just have enough paper for your photocopier not to run out, and I'm sure nature intends us to have a vitamin D level that's away from the sort of thresholds for pathology. In the old picture, vitamin D is important for bones. In the new picture, it's important for almost every organ system in the body. I think yesterday and today, I think there's a bit too much of a move to thinking that it's really just everything is through the immune system. I mean, clearly the immune system is important, but we've also heard from the microbiology side that virtually every cell and therefore every organ system in the body is affected. And in the case of cancer, whether it's differentiation, proliferation, apoptosis, everything that we consider to be indicators of cancers, there's a molecular pathway which involves vitamin D, so it may have a direct effect. In the old world, medical professionals, almost all of them know about vitamin D, but what they know about vitamin D is that you don't want to take more than a small amount or you'll die. It's toxicity. Almost every doctor I deal with, their main reaction to me suggesting anyone has vitamin D is a weird fear of toxicity. In the new world, I think that sometime we'll get to a point where the medical profession just couldn't understand why you would ever let anyone have a sub-physiological vitamin D level, and toxicity would be considered a non-issue. In the old world, which we're in I think we're in an interesting transition between these two worlds, and that sort of is a very uncomfortable place but exciting place to be. And we're closer to the old world. In the old world, you can have someone give a presentation on a non-toxic, almost free drug, which in a very well-designed randomized clinical trial reduces the incidence of cancer by somewhere between 2- and 4-fold, depending on how you do the analysis. And the lecturer, Joan, who's going to give that talk, can be booked at short notice, and there are hardly any oncologists in the audience. I'm looking forward to the time where we have to book you a year or two in advance, Joan, and when there's 1,000 people in the audience, because it's really difficult as a layperson to understand why this isn't considered more important. For me, Joan, I've been following the vitamin D story since about 2004 when I picked up Bill's publications and the Golan publications, or maybe it was the Golans and yours came, I've forgotten the exact. And it was fairly clear that there's a huge pattern of evidence in cancer and other diseases that low levels of vitamin D were probably pretty bad for you. But that still left a proof of principle that supplementation would make a difference. I mean, in cancer, it could well have been the case that by the age of 50, increasing your level by supplementation was too late. It could have been that that there was something about the supplementation pathway that didn't work. And so Joan's trial, I think, was really sort of almost a religious experience for me when I came across it, because it took all of that circumstantial data and provided a very decent statistical proof that actually low vitamin D levels are causative, and B, that in those patients who presumably effectively all had cancer in situ but below a diagnostic level, actually at that stage, vitamin D was pretty effective, and it was delaying most of those cancers by 4 years. I mean, in your trial not only do that, I've looked at thousands of papers on cancer trials, and your Kaplan-Meier curves are sort of beautifully smooth, which is a nice indication. And although the ends are small, to see the effect on lots of different cancers was very encouraging. So we look forward to the future results. I'm still not quite sure what benefit we'll get from late-stage intervention. There's one of the oddities in the vitamin D data is that it seems that either a prior history of exposure to sun or prospective vitamin D level means that in at least certain cancers, your stage of cancer is no longer independently diagnostic of survival. In other words, a better sun exposure means that when you get cancer, even if you grade it carefully, you then do better than other people with lower grades. And then that's also perhaps a reflection that in the African American communities, not only do you get sort of almost every cancer more often, but when you get it, you're more likely to die from it. That leads one to hope that the late stage cancers can be improved by raising vitamin D levels. But metastatic cancer is about 1,000 different diseases simultaneously, and so it might not be that good. But my view would be that it's still beneficial to the patient to correct their vitamin D levels at that point, because those patients have a physiology that's under stress in almost every organ system, and they're feeling pretty awful because of that. And if you just if you correct the vitamin D level, you'll probably improve their immune system and their renal function and their muscle function and everything else. And so the palliative benefits would probably justify it alone. The vitamin D, we've had talks about vitamin D in general, and yesterday was obstetrics and young children. If you look at all the different diseases, I think in terms of the observational data, cancer is the most complex. Cancer is, it's very complicated. It may arise at very different times. And so it has a number of challenges, at least in understanding the epidemiological data. And there is this issue of the U-shaped curves. And I think that while one can probably correctly criticize some of the most frequently quoted trials, studies, was it Reinhold V who yesterday showed us an analysis which was testing one of his hypotheses, which is that actually having a very high vitamin D level if you live in a very northerly latitude means you're also going to have a very highly fluctuating vitamin D level, and that in itself might be a bad thing. So if we go to the observational studies, what the pattern I've noticed, I think from Bill's papers and others, is that there's more consistency in the data on where you lived. So the UV exposure seems to be a more predictable and easier to understand data in terms of incidence than the prospective data with 25 hydroxy levels. And we have to remember that people in northern latitudes with high vitamin D levels are not the same as people who were living near the equator 10,000 years ago. Near the equator 10,000 years ago, you had sun exposure every day, 365 days a year. Your vitamin D was derived from sunlight. You had daily dose of D3, and there was very little fluctuation in 25 hydroxy levels. In our current observational studies, you have a very high vitamin D level if you're in a northern latitude, either because you have taken sort of summer holidays and you have this sort of 4-week, or if in the United States you don't get 4-week holidays, you have 2 weeks in which you get this huge boost to your vitamin D, maybe once or twice a year, or in the Scandinavian countries because you eat a very unusual amount of fish, or at least a very large amount of fish. Neither of these are physiological reproductions of what it's like to live in Mexico. And so it could be that that data needs to be interpreted carefully in that sense, that these are not, that having a high vitamin D level in a northern latitude because of daily supplementation may produce a much more physiological type vitamin D level over the year than the people in the current observational studies. You haven't eaten a lot of fish, and you're not just getting 1 or 2 pulses a year. And then a thing which I sort of consider a bit of a warning, most of the people in the observational studies, and most of the people, whether they're prospective studies or latitude or area of residence studies, have a high vitamin D level because they've been in the sun a lot and they've made vitamin D through sunshine. When we give vitamin D as a supplement, there are significant differences between that and those studies. The vitamin D is given orally instead of made by the sun. The area under the curve, so the half-life of the vitamin D is quite different. It's bound to, sun-induced vitamin D is bound to vitamin D binding protein, and dietary supplement vitamin D is bound to cholesterol. I'm not saying there are differences, but there may be differences. And when we do trials where we give the vitamin D very intermittently, we're then putting in very big differences in terms of what your dose of D3 is. And as a physicist, I originally got interested in this because speaking to Gus, I was wondering what we might do to upregulate people's DNA damage management mechanisms. And it seemed to me giving them a sun exposure would be a good way of doing it because you get a lot of DNA damage when you go in the sun. And I thought vitamin D might be a signal for that. But 25-hydroxy vitamin D doesn't really change much when you go in the sun. It'll change after 6 months. But you can't look at a patient's 25-hydroxy vitamin D in the middle of the night and see whether they went in the sun that day. But you can look at their vitamin D3 levels, and it does tell you if they went in the sun that day. So as a physicist, I would be surprised if the body didn't use that signal or some other sun-derived signal to upregulate short-term DNA damage management. So sort of my advice to the most conservative people, if you really want to avoid cancer, is get yourself a high UVB sunbed or go and live in a nice high UVB area and take a daily exposure to the sun. And I would also, while I accept that there are members of the community where that's not practical, including myself most of the time, there are other benefits of sun exposure. I mean, half the world is on Prozac, and we do know that when I looked at, well, what other molecules are made by sun exposure, one of them that's made is a beta endorphin, and so therefore the normal human being is getting a beta endorphin dose every day, which the modern person is not getting. And I got into this because my wife had advanced kidney cancer, and so being me, I got her a high UVB sunbed, and she religiously stuck to getting her 20 minutes of sunbed every day, and Gus would remark on her incredible tan. And so I really asked her, why did she stick to that when she didn't stick to lots of other things? Because when you've got advanced cancer, it's difficult to stick to other things. And it's because that it gave her a daily a relaxant. It was enormous, it was like taking a very effective Valium once a day, and it was just very de-stressing. So a vote for sunshine. There's some oddities. I mean, there are going to be lots of oddities in cancer because there are going to be certain cancers that are going to be vitamin D resistant for some reason, others aren't. In doing my homework for this week's conferences, I came across again a paper on prospective study of 25-hydroxy vitamin D levels in colorectal cancer, and they split the groups into those where the colorectal cancer is diagnosed in summer and I think it's summer and spring, or summer and autumn versus winter and spring. And there was a huge correlation between, if you're in the highest vitamin D level, you had a risk ratio of 0.24. So you had a 4-fold reduction between the lowest and highest quartiles of vitamin D for those cancers diagnosed in summer or autumn, and none for the cancers diagnosed in winter and spring. And the N in both cases was about 150. And so it sort of raises the sort of possibility that you've got certain vitamin D susceptible cancers and certain ones that aren't. Or it's a complicated picture. We have this thing that I mentioned before that not only does it affect incidence, but as Bill data showed, a paper showed some time ago, that actually you're less likely to get it, and if you get it, you're less likely to die from it. So the mortality is got the bigger, the overall effect on mortality is even bigger, because if you didn't get it, you're not going to die from it. But if you get it and you're less likely, you get two benefits, which is quite nice. In the UK, so we look at something like John's data or other people's data, and I think in the UK, as David and Oliver pointed out, it should be even more important here. I mean, we'd love to have your baseline vitamin D levels. Here, we go between an average of 35 nanomolar and then 75 nanomolar, and therefore, whatever the benefits of vitamin D level correction that one might deduce from much of the US public literature, the benefits in the UK should be higher, and the UK in general. And then if we go to subpopulations, whether it's an Asian community or an Afro-Caribbean community or my friends in Glasgow, the effect should be even bigger, and it should be a more important issue. We have the sort of next questions, which, if it's good for you, what else can we do? Kayla talked about, illustrated to us why the calcium may be synergistic with vitamin D on a sort of direct basis in colorectal cancer. I think John's data suggests that calcium may be good for you in other cancers, but without any understanding of how, if your calcium level, serum calcium level doesn't change, how did the other cancers know that you ate more of it? But it'd be interesting to see where that goes. Gus has already found in vitro a number of synergies with some of the thalidomide analogs. I discovered some paper which showed that in vitro melatonin sensitizes tumor cultures to proliferation inhibition by vitamin D by 2 log units in terms of the vitamin D strength. And normal sun-induced vitamin D peaks in the body at about the middle of the night, which is also when melatonin peaks. So in Carol's study, I've asked Carol if she can add the question of what time of day do you take your vitamin D? And maybe when we design vitamin D trials in the future, we should be specific about half the cohort taking it in the morning, half in the evening, or at least knowing what time they take it, to see if we can illustrate questions like that. And no doubt we'll find all sorts of other things which are synergistic, or maybe like vitamin A, which looks as if at some level or other it's antagonistic, although my starting point is what's natural is good, and therefore I would be surprised that if your vitamin D level was completely physiologic, that vitamin A would be a problem. So my guess at the moment would be that vitamin A is a problem when you're still suboptimal in your vitamin D reserves, but the data will speak for itself when we get it. And if I can get this to scroll down. The other thing, as a couple of the speakers mentioned, is that it's not just cancer. So while there may be all sorts of question marks as to whether correcting your vitamin D level is or isn't a good thing for cancer, based just on the cancer data, when you look at the other diseases, you've got to really say, well, hang on, the case that having a low vitamin D level is bad for you is pretty overwhelming, because it's not just one disease. It's about as many diseases as you care to look at. In fact, I think you could list all of the modern, most expensive pathologies, in descending order, and throw a dart at them, and you could be pretty sure that you'd pick out one that was seemed to be vitamin D related. So I think that's important in both deciding what's right. It's also important in a different respect. I mean, if it becomes overwhelmingly clear from the point of view of whether it's osteoporosis or multiple sclerosis or cognitive degeneration or infectious diseases or pregnancy, that your 25-hydroxy level should be above 80 nanomolars, then are you're going to take that at the age of 50 anyway. You're not going to not take it because there may be a little bit of a U-shaped curve somewhere. And so I think that the others disease issues actually make the questions of what to do in treatment more straightforward. It's clear that the IOM type bodies and the Scientific Advisory Committee on Nutrition type bodies aren't used to addressing a question where you don't have relatively clear-cut data. And in vitamin D, I think we've got this fairly clear-cut picture in one sense, but not within a frame that they're used to working with, which I think it's becoming overwhelmingly clear that a physiological level of vitamin D is somewhere between 100 and 200 nanomolars, roughly speaking. Therefore, that essentially everyone in the developed world is vitamin D deficient, and that we're getting certain disease conditions where there's some randomized controlled trial data to show that fixing that seems to be a good thing. We certainly now got very good data to say that fixing it is not toxic. So from my point of view, it's a really easy decision. Should you have the level of vitamin D that nature designed you to have? Yes, it's non-toxic, it costs nothing, and it doesn't, and it might save your life and dramatically improve the quality of it. And the downside is that maybe somewhere there's a little bit of a U-shaped curve or some other interaction with something, but it's not a complicated decision. But that's very different to the framework that IOM and SACN live in, where really, unless you have randomized controlled trial data at the level we're talking about, it's difficult for them to give the right advice. So I don't know how we resolve that, but I think partly the answer is to have bodies other than the IOM and SACN make recommendations, and I think it was Reinhold yesterday was saying that actually that's happening quite a lot in North America. So people other than, that there are clinical advice and there's advice which really is driven by the food industry, and we shouldn't confuse the two, although we are. So that just leaves me to thank the speakers, a fantastic group of speakers today, to thank Rufus for having the idea of piggybacking on our German colleagues' talks to get such good speakers in, and to thank the members of the audience for coming. So give